My name's Laura Smith. In my normal day job, I am Director of Workforce for an organisation called Leeds Community Healthcare, which is unsurprisingly in Leeds, and also Director of Workforce for the Leeds GP Confederation up here in Yorkshire. I am one half of a job share partnership in this role with my job share partner, Jenny Allen, who some of you may have come across before alongside me. Jenny's tech didn't work today, so I'm flying solo today. Okay, so we're here to talk about systems working, community and primary care. So LCH is a community organisation. Leeds GP Confederation represents the voice of GPs in Leeds, 97 different practices across Leeds. And really what I wanted to do is share a story with you today about how we have sought to work in a more integrated way across community and primary care, and specifically assist our GPs in delivering some of the demands of the GP contract. I want to talk a little bit about what it's taken to get to that point, exactly how we have sought to support them, what some of our learning has been, and also how that's potentially stood us in good stead for hopefully working together more closely with primary care in the latest challenge that we're about to face, which is the delivery of the COVID vaccination. Please do pop in any questions or comments into the chat box as we go. Right, thank you very much. So Lauren, I'll ask you to move the slides along if I can. So can we go straight to the second slide, please? I should say, everyone, what sorry, back one, Lauren. Thank you. I should say as well, I'm going to tell this story, and I hope we'll have the opportunity to have a chat at the end, take any questions. I'd love to hear about what's happening at your end in terms of integrated or partnership working between primary and community care, or indeed across health and care systems in general. So Leeds Community Healthcare NHS Trust, which is employer, if you like, we're a 3,000 strong organisation, and we deliver over 60 services to the population of Leeds and beyond. We seek to work in partnership where we can. Leeds as a place has a strong partnership working ethos across health and social care, and we seek to also play as a team within our ICS footprint, which is West Yorkshire and Harrogate. Lauren, can you move me along one, please? So what I'm talking to you about today is specifically our relationship with primary care and PCNs and GPs within primary care. Interesting, I thought that when I was looking for a picture for this slide, I was overwhelmed with pictures of white male GPs and not very many good pictures of other GPs. So a white male GP it is, which is indeed representative of plenty of our GPs in Leeds, although by no means all. We are relatively diverse as a city. What we find as a starting position in Leeds, and myself and Jenny have been working alongside primary care for about 2.5 years now in this role, is that we come initially from fairly different perspectives. I think naively, Jenny and I had thought when we came into position that as a community NHS provider and GPs in primary care, we were working towards a single common goal, which was to improve the health outcomes of our population, and in doing so to reduce health inequalities. What we found was that GPs absolutely have that perspective, they do, but they have a whole other of perspective linked to the nature of the GP contract and the way in which GPs provide services to the populations that they serve. And of course this goes all the way back to 1948 with the birth of the NHS, when Nye Bevan, in order to keep the BMA on side with the birth of the NHS, enabled GPs to continue to operate as private practitioners, and he also made some arrangements with hospital consultants. There's a famous quote from Nye Bevan at the time, I think, where he said, "I stuffed their mouths with gold I'm not sure there's that many GPs in the system working today who would feel that their mouths are full of gold, but nevertheless they do work very much as independent contractors, of course, running their own businesses, which means that they have to put a very different layer of questioning and perspective in front of any sort of decisions that they make about the services that they provide. Whereas for us in the NHS, sometimes it feels that we are much more easily able just to go straight to the main goal, which is about patient outcomes and reduction in health inequalities. I'm just going to pause and answer Stephen's question in the chat box. Stephen, the answer is, in terms of separate community services trust, it goes back to Transforming Community Services agenda back in 2011. Leeds, and this was before my time in LCH, Leeds had originally pitched to be a community foundation trust, then a community interest company, and eventually settled as just a community provider NHS trust. It is rather unusual. I think there are only 14 community trusts in the country at the moment, and many, as you say, Stephen, are combined either with acute trusts or, as in our neighbours Bradford, in the provision of mental health services as well. So we are relatively unusual. You'll sometimes hear our Chief Executive, Thea Stein, talking about us as a boutique operation. It's a lovely organisation to work for if anybody's considering coming to work in Leeds. Is a traditional GP model, again, Stephen, business under contract with national contracts, suited to the needs of integrated service delivery? Well, Stephen, I hope that the answer to that question will become clear through this presentation. I don't think it's necessarily a straightforward answer, to be honest. Lauren, can you move me along 2 slides, please? Okay, brilliant. So I've skipped over a slide, which is just a picture of the front of the GP contract, so the GP national contract. I'm not sure who I have in the virtual room with me. I'm sure most of you already know this, but the GP contract, of course, is contract for service under which GPs deliver their services to their own practice populations. You may also be aware that the most recent iterations of the GP contract compel GP practices to begin working together at greater scale in primary care networks of between 30 and 50,000 patients. So just to give you a sense of scale, in Leeds, which is approximately 800,000 population, we have 19 primary care networks of varying sizes and all in varying stages of maturity, complexity, and business readiness, if you like. Now, within the GP contract, GPs are having the opportunity to bring in a number of brand new roles under what's called the ARRS scheme, the Additional Roles Reimbursement Scheme, which, for those of you who enjoy acronyms and how they're said, ARRS offers all kinds of fun opportunities if you try and say it, not initials, but as a word. The ARRS scheme has just over a dozen now roles within it, 26,000 in total across the country, across various professions. And it gives PCNs the opportunity to bring in these roles to diversify their workforces and just provide even better services to their population. However, the resourcing and employment arrangements are potentially complex, and from a GP's perspective, they are fraught with some risk and liability. What I mean by this is funding under the GP contract is time limited. So for many of the ARRS roles, see, I'm nearly saying, we try and say R's in Leeds, R's, the R's roles, they are time limited. Originally, they came with only a proportion of the funding, and PCNs, so these groups of practices working together, are understandably really puzzling through the tricky conundrum of who should employ these roles. This is a group of practices, a group of independent contractors, independent businesses working together. Who employs these roles? How do we take on the liability for things like redundancy? How do we cope with taking on a single paramedic or a single dietitian or a single clinical pharmacist and having them in isolation in our PCN? What happens when that funding comes to an end and we've got no ability to redeploy that member of staff? So we had a number of PCNs who were having those anxieties, if you like. Can you move me on to the next slide, Lauren? So we, at LCH, Leeds Community Healthcare, we thought, well, we can help here in terms of furthering our agenda to work closer together in an integrated way across primary and community care. We've got something to offer the GPs that takes away some of these anxieties that they have about the employment liabilities, professional and peer support, and frankly, the costs associated with employing and deploying this new workforce. Can you move me on again, please, Lauren? Thank you. So we decided to say we can help, and what we did in a nutshell was develop a new model of employment and deployment so that we could say to GPs, we will take these staff, if you want, onto our books for you, and we will work with you to deploy them. So Lauren, can you move me on again, please? Oh, crikey. Thank you. So LCH, we're not a massive organisation, but we do have significantly bigger infrastructure than any individual primary care network. And we can realise economies of scale that PCNs can't, for example, in employment administration, including running resourcing campaigns across a whole suite of PCNs for a single role, shared selection processes with PCNs involved. We can manage the pre-employment checking, the contract issuing, and so forth. What we also offer under this model is to employ staff in LCH under Agenda for Change terms and conditions, which we're finding is something that GP practices find very difficult to offer, but is a significant attraction and retention measure for the kind of people, and particularly the registered professionals, who might be interested in doing one of the ARRS roles. This gives us the opportunity to work really closely with our 19 PCNs. So the relationships that we had started to build informally through the GP Confederation, through smaller pockets of integrated working, for example, in joint wound care clinics, it gives us the opportunity to build on, deepen and strengthen those relationships with each of the individual PCNs. We provide professional support networks across the professional groups of staff. So clinical pharmacists, for example, working in PCNs have their own group. We're doing the same for a new advanced support worker type of role. And we provide the service at extremely low cost. And I can't emphasize enough really how important that has been in securing the buy-in of GPs and primary care. To be specific, we offer this employ and deploy contract at 2% of gross salary, which in no way covers the costs of employing, deploying, supporting this workforce. We've deliberately offered it at such low cost as a means of being able to test and pilot how it works, so that GPs were incentivized to work with us, and hopefully will work with us on developing the model. And at some point, we may need to cost it at what it actually costs us to provide. Can you move me on again, please, Lauren? So in terms of the contractual mechanics of the model, we operate our employ-deploy model under a service level agreement, essentially, which we developed with the PCNs, but also with specialist legal advisors. Anybody who's on the call who might be thinking about doing something similar in your own organisation, first of all, we'd be happy to share our documentation and our learning. But second of all, it is really important to get specialist legal advice in this arena. We had to get advice in particular, for example, about how this would work in terms of VAT, given that the staff being employed in an NHS organisation and deployed in a non-NHS organisation. I can see that there's some questions coming up in the chat box, which is brilliant. I'm going to get through a last couple of slides and then I'll come to them. Please keep putting the questions in, that's super. We also, in developing this model, we spent a really long time with GPs, practice managers, other primary care network partners to try and thoroughly understand what their perspectives and needs were. And if I'm perfectly honest, we spent a lot of time trying to rationalise our own very deeply held and felt ethos of it all being about patient outcomes and reducing health inequalities, and starting to understand in more detail the very real GP as business perspective, where the partners have to make sure that their whole business can keep running in every decision that they make. So that's been a really useful learning curve for us, just understanding wise. In the latest iteration of the GP contract, or at least in the February iteration, GPs were actually, PCNs have actually been encouraged to work in partnership with NHS organisations around the ARRS roles. We started our piece of work on it probably about 6 months before that, so it was great to see that February iteration almost kind of sanctioning the work that we were doing. So we felt out on a limb a little bit for quite a while. In terms of how the model is working, we now in LCH have 40 employees across a range of professions who are working out in PCNs, and we have several dozen more on the stock. Some of them have gone a bit slower in the past couple of months for obvious global pandemic reasons. But the model is gaining traction. It was never mandatory for PCNs to use it, and a number of PCNs absolutely prefer to go their own way, and that works for them. But we now have, I think, 14 out of the 19 PCNs who have at least one role from their ARRS roles, either directly employed with us or in the pipeline with us. So we feel confident in its value as a model, and we do regularly now get asked to share the model that we use with other places, and it's one of the reasons I think why we were asked and we're keen to share it with you today. Can you move me on again, please, Lauren? Thank you. This is my penultimate slide. I talked about the opportunity that developing this model gave us to deepen and strengthen our understanding of and relationship with PCNs. What we are finding at the moment, and I probably should have said at the beginning, I've currently been sprung from my day job as Director of Workforce to work as Workforce Lead for the COVID vaccination programme in Leeds. And those relationships with PCNs have never been more important as we contemplate the delivery of a vaccination programme to our adult population in the city together as a health and social care economy. Some of the principles of the employ-deploy model, we're looking at how we can use that during the COVID vaccination programme, and you'll see that I have very deliberately not put anything on my written slides about this, but I will share verbally, and I do know that we're being recorded. We're working to see how some of the principles of the model might assist us ensuring that primary care, when it's delivering the vaccines that it can deliver, has access to as many supply routes for workforce as we can possibly facilitate for them and with them. Can you move me on to my final slide, Lauren, please? And then we'll go to hopefully a bit of discussion and question and answers. Okay, so this is absolutely an iterative and learning process. I don't think we're at the end stage yet. I don't think the model that we have is the final model. It's not written in stone, and what works for Leeds won't necessarily work for other places. But what we've learned is that we have to start from a position of trust. It took some time to get to a place where we could even have a conversation with PCNs and GPs about the notion of this model. Starting small helped us a lot. We started with the clinical pharmacy role and just a couple of PCNs and built from there. And as you can see, we're now at 40 and it's built quickly. We've tested and adjusted. Even now, the model is not quite as it was when we first put it in. We've learned a lot about how we describe clinical governance, how we describe induction and peer support within the model's documentation in a way that makes sense for partners. Price sensitivity, I almost put this at the top, but I reflected and felt that actually price sensitivity is a function of being an independent business and an independent contractor. It is high on GP agendas, is our experience in Leeds, understandably so, I think. But going in with a model up front that was going to be charging at what it actually cost to deliver it wouldn't have gone anywhere. So we're still treading very carefully in that space. It's a very price sensitive area of the system to work with. Ultimately, we think that we've made the best progress when the interests and benefits of the various parties are aligned. It's the same interest and benefit alignment is showing itself to be true during the COVID pandemic. So that seems to be holding true for us. I guess, again, not a surprise. And the final thing, this is, as I say, my last slide, we found that this model really works. I think we need to work harder to make sure that it works for LCH financially, rather than being purely a loss leader, but as a concept of integrating primary and community care for spreading risk across the system. It absolutely has worked for us. So I'm going to stop there. I think there are too many of us, unfortunately, in this room to have us all on screen at the moment, because I understand there's a maximum of 9. But Lauren, can I suggest, and tell me if this is a good suggestion or a bad suggestion, should I take questions from the chat box first of all? And if people who've asked questions in the chat box want to come live on the video, so turning on your microphone and camera to ask questions, I'd love that. It would be really lovely to see some other faces. Good idea. Okay, says Lauren. So can I go all the way back to Stephen from NHS Employers, because I know you wanted to make a point of clarification about the GP contract, and then I don't know if there are any other questions that you wanted to ask. Stephen, would you be up for coming on screen? I think Lauren can facilitate that for us. I think there's probably a button on your screen that says ask to share audio and video. Can I just direct people in the chat box to Stephen's point about NHS Employers? NHS Employers used to administer the GP contract, but it's now with NHS here we are. And improvement with DHSC. Stephen, hello.
Welcome. Sorry, I was surprised. I should have put a hoodie off and put a tie on.
Oh, sorry. I see. Sorry, I put you completely on the spot. You would have looked lovely in a hoodie, but nice jacket.
I'm trying to combine the informal and the formal. Yeah, just a bit of history, and not to go into the lengthy history for it. Just to say, and I'm not going to. There were pros and cons for how it was organised, and there always have been pros and cons for how it's been organised. It's gone back and forth between the Department of Health and Social Care having responsibility for it, NHS Employers having responsibility for it, and now NHS England and Improvement having responsibility for it. But the fundamental model, as you said, hasn't changed, of independent businesses being contracted to work for the NHS on a national common basis, which is quite unusual. The NHS doesn't do that with care homes. It doesn't do that with independent social care providers. It doesn't do that with a range of other non-public bodies that supply services to the NHS. That's not a criticism in case there's any GPs who feel that it was a criticism. It's just an observation. Do you think that model might change completely to move away to something even more complex, maybe even place-based, as we develop integrated services?
Crikey, Stephen, I wasn't expecting that kind of question.
I'm not advocating that. It's a possibility.
I don't know. The model as it is working okay in Leeds. I'm not sure how sustainable it is exactly as it is. I'm not sure whether there would be the level of trust nationally or indeed amongst GPs to introduce a particularly place-based arrangement. What do you think from an NHS employer's perspective?
I'm very aware this session is being recorded. I'm speaking here purely in a personal capacity. I think you're right. There's an issue of, it's gone all the way back to the original relationship between the GPs and the NHS as a whole. So I think any development needs to be very careful. I'll be careful in how I present that. There have been some experiments in some places with, like you've hosted people as an employer. In a few places, people have employed GPs directly as employers on a voluntary basis in areas where it was difficult to recruit GPs to operate as independent practices. And I think on a voluntary basis, that can work quite well. There's been, you probably know this more than I do, some GP cooperatives, or GP-led cooperatives, I should say, have emerged in some areas as an alternative model. So keeping some of the strengths of the GP model as independent businesses, but working more as a cooperative.
Yeah.
But usually quite a business-focused cooperative, and I think that's the important point you raised before. These are not sort of the type of cooperatives we had in the 1970s that didn't consider how the business should actually run. They're very much trading, but trading in order to provide services, not to generate a profit.
Absolutely, and that needs to be really clear. They have to make enough money to run their premises, to pay their staff, to pay their bills, to pay for their consumables, and so forth. So I'm absolutely in no way criticising GPs as business owners. And I know that you weren't suggesting that I was. In Leeds, we have a single GP confederation which aims to represent the voices of GPs, but we also have a small number of confederations and clusters of GPs that run themselves in a very, very business-focused way, bidding for services. And you could see that increasing in the future. One of the other things that we've actually been looking at with primary care is whether we can operate some form of staff bank in partnership with them that could include GPs, as you describe, practice nurses in particular, working on a similar sort of basis as employ-deploy, where we could offer the infrastructure, the peer support, and so forth, and perhaps provide some workforce security and agenda for change terms and conditions that practices find it difficult to offer at the same level themselves.
Thanks, and good luck with the vaccination programme, by the way.
Oh, thank you very much indeed. I appreciate that. Yes. There's a question in the chat box from Amanda Price. I'm cautious about putting people on the spot, but Amanda, if you did want to come on screen, that would be great, and just click on the button that says "Ask to share my microphone and video." If you prefer not, I'll just wait a second.
It's worked.
Hi, Amanda. Thank you for coming on the screen.
Hi. No, this
love your question.
Oh, thank you. Really useful and practical session. Thank you. Yeah, so the question was thinking about staff who were already employed by GP practices. For example, you just mentioned practice nurses, what their view has been around working with colleagues employed by the community trust.
Okay, so I love this question because it goes to the heart of some of the challenges that we have in our integrated working, just in a really practical way. Some practices in Leeds do operate agenda for change T's and C's. Lauren, do we need to do some muting somewhere just so I'm getting feedback? Oh, perfect, brilliant. Some practices in Leeds do operate more or less mirror agenda for change terms and conditions. Most really struggle to, and there are some elements of agenda for change, in particular, for example, the redundancy entitlements and the big jumps incrementally in the pay scales that GPs fail to follow. We have not so far had significant negative feedback or rumbling, either from the staff employed under the employ-deploy or from practice staff about what inevitably in some practices will be a disparity in terms and conditions. So absolutely recognise there will be a disparity, and more so in some practices and PCNs than others, between what those ARRS staff are being paid and what their compatriots who they work with day by day are being paid. But that hasn't manifested itself as a problem that would be a deal breaker either for the individuals involved or for the model as a whole. But I think I'm glad you raised it, Amanda, because that's a very live issue that can sometimes get in the way of our integrated working. Thank you. I don't have any other questions in the chat box. Oh yes, we do. Shelley. Hello, Shelley. Do you want to come on screen? Hi, Shelley. Good to see you.
Good to see you.
And of course, you've got some very particular knowledge about our system.
Yes, but I'm. You can actually see me?
I can hear you, but not see you just at the moment.
Oh, right.
We can hear you loud and clear.
See how it's working. I don't know why it's not working. 1 second. Let's cancel this. But you can click twice to maximize video. I don't know why it's not working. Anyway, you can hear. Well, I'm here with my not my day job hat on, Laura. I'm here with my trustee of HPMA hat on, but you know, we have worked together in the past. So the question I wanted to ask is, on behalf of the HPMA community, I really don't know why you can't see me, but anyway, the practicality. So if you think about people who are working in CCGs and people working in providers, the way that the system is going to be going in a much more integrated way, we all know it's great to collaborate and create trust and understanding. But one of the things that our members want to know is, you know, how do we do that? What are some of the really practical things that you have done? I know you've explained some of it in the presentation, which was great. But on a, you know, when you're thinking about all the different interests and walking in their shoes, what are some of the practical things that you can do to win hearts and minds?
Oh, that's a lovely kind of OD positive change question. Thank you for that question, Shelley. I'll enjoy answering that. So some of the tips I think I've put in on the final slide, but in really practical terms, I think we had to very consciously put some of our assumptions to one side. So we realised that we'd come with the assumption I described, that we were all just shooting for this same single goal about outcomes and reducing health inequalities. And it was a conscious decision to take that assumption. I don't know why I've just described it as a hat with my hands, but to set that assumption down and literally physically sit alongside GPs and practice managers to get an understanding of what their world is like. So both Jenny and I have been out and physically, it feels odd, doesn't it? It's COVID that's making me say physically, been out to GP practice. Oh, hi Shelley, we can see you now.
Yeah, I realise now.
Sat with practice managers, sat with GPs, chewing the fat, and sometimes very informally over a coffee, sometimes in a very business focused way, discussing this model itself. But we took a lot of time, and this was also building on previous relationship building stuff, to really try and understand them, almost literally walk in their shoes and get a flavour of what would this look like if it was successful for you. You can't come at it from what will it look like if it's successful for us. And we realised we can't even come at it from saying what will it look like if it's successful for the patients. We had to truly understand the GP perspective. And then the other massive key was starting small and testing and adjusting it, because you lose your reputation with 1 or 2 GPs and you've lost it with all the GPs in your patch. So you really have to be steady and firm on your ground and progress slowly. This isn't something to do quickly. Does that give you a reasonable
really helpful
answer?
Because I think that's the point, is about the investment of time that in forming these relationships, and when we're pressured with so many things, and especially at the moment. But I think one of the benefits of doing things virtually is that you haven't got all that travel time, and you can have a virtual coffee and you can still form very helpful relationships. But yes, I really think you've done amazing work, and there's a lot of information that people can gain from you in how to deal with the changing situation that people are going to be finding themselves in the next few months. So thank you so much, Laura, from the HPMA trustee community, for answering that so well. Thank you.
Thank you, Shelley. That's really kind of you to say. And I can see that there's agreement in the chat box as well. Just while we're mentioning HPMA, and of course we're here today as part of the HPMA conference, I must just put in a plug on behalf of myself and my job share partner, Jenny. We are vice presidents for the HPMA in Yorkshire and Humber. And if any of you on the call today are part of our Yorkshire and Humber community, we're always welcoming of new committee members, new ideas, and just generally chats with people about what they would find useful. So very welcoming of people getting in touch. I can see we're coming up to the end of the session now. I can see Gareth in the chat box seeking a conversation. Yeah, absolutely, no problem. And Lauren, if it's not against rules, shall I just put my email address in a note in and let me know if that's permitted? Yes, please do. Okay. And while I'm doing that, I'll just pause to see if there are any other questions coming in on the chat box that I can answer before we close the session. So I'll just put my email address in while we're waiting. That's my email address. You'll notice it's a shared email address with Jenny. That's how we roll as a job share partnership. And either of us will be very happy to hear from you, Gareth, or indeed anybody else who's taken the time to join the session who wants to get in touch. Lauren, I think I'm going to draw the session to a close now as we come up to 1:30, unless you type in the box and tell me otherwise. I want to really thank all of you for taking the time to be with us this afternoon. It's lovely to be able to tell our Leeds story. I hope that you might have found it useful, or if not useful, then at least interesting. And if there's anything that you'd find helpful in terms of follow-up conversation about how we do things in Leeds, absolutely don't hesitate to get in touch. So I am going to close the session now. I wish you all a really super afternoon in what is so far a really fantastic conference, and perhaps speak to some of you again soon. All the best, and thank you for joining us. Bye-bye.